Hello, good morning, everybody. Lovely to see so many of you here. You're very welcome to this morning's session. It is part of the HCI webinar series. My name is Oonagh Gilvarry and I'm the Chief Research Officer here in HCI. This morning, Rebecca McAuley, our best practice specialist, will be presenting on some of the key non-conformances that were identified from a selection of recently released HIQA inspection reports from designated centres for older people. We'll also be joined by Tanya Nee from Business Development, who's also going to provide us with a short demo at the end of the session. She's going to present Cloda, which is one of our digital solutions that's going to be able to address some of the issues that we present on today. So thank you for taking the time to join us. Just before we get into the non-conformances and the analysis that Rebecca has completed, I just wanted to highlight a report that was recently released just on the 15th of June, and that was the 2025 annual report. So it set out the work that HIQA did in 2025 and how they believe they've achieved their key outcomes in Ireland. So it's looking at their measurable impact as they see it through setting of standards, regulating and monitoring health and social care services. So if we have a little look of some of the content that relates to nursing homes specifically, we can see that there was a small increase in the number of beds from 24 to 25. And in relation to the profile of ownership of nursing homes, unsurprisingly, the private providers providing the significant number of registered beds with just over 80% of those services being provided. Unsurprisingly, the number of inspections, the vast majority of the service providers carried either one or two inspections, and unsurprisingly, 95% of those were unannounced in 25. The enforcement actions conditions approved to vary and insurance reports requested. Again, the significant enforcement actions requested by HIQA with just one district court application over the course of the year. When we look at the focus of inspections or how they have presented it, their significant change was that update to the Health Act, which was implemented from the 31st of March. And all of those changes that came into effect had significant impact in relation to the requirements from providers, but they arose from the COVID-19 nursing homes expert panel. And the aim was to modernise and enhance the legislative framework that was there. It certainly, as I said, had significant impact for the requirements for providers, but it also gave more powers to the chief inspector to improve oversight to ensure the quality and safety of care being provided. One of those specific oversights related to safeguarding, and certainly there was a big focus in 25, and I would say remains the case in 2026 in relation to regulatory compliance on safeguarding. And they identified and they made it clear within the report that they feel that there's further work needed in relation to this element. They felt that there was focus required in relation to staff training for safeguarding and looking at trying to strengthen provider safeguarding surveillance systems so that they could identify and respond consistently to safeguarding. Now, safeguarding is something that's going to come through in the presentation. A lot. Rebecca is going to be touching on it also within her content. And she's also going to flag at the end, and it's important to flag it now too, the National Safeguarding Office has updated their suite of guidance documents as they relate to safeguarding of adults, vulnerable adults. They are currently available on the HSE training website, and their date of application for effective implementation is tomorrow, the 1st of July. And there are some significant changes there, additional requirements and expectations in relation to safeguarding processes and also in relation to the reporting requirements. So it's important that you are aware of those and incorporate them within your process and roll out training in that regard. In relation to the rest of 2026, we're halfway through now. Is there any expectations of further changes? I'd say the regulatory framework the landscape is pretty settled currently, although there is always continual ongoing review of guidance documents. They did detail in relation to their corporate plan for 25 to 27 that following the recent developments on the nursing home sector, that they'd continue to review the effectiveness of their regulatory process across the health and social care sectors. But currently, I would say there is an additional focus in other areas of health and social care, but they're not going to forget about us, I'm sure, in relation to nursing homes. So I'm going to hand you over to Rebecca now, and she's going to bring you through the HIQA inspection reports and some of the key findings that were there, so we can identify some learning and trends across the board. So I'll hand you over now, Rebecca.
Thank you very much, Oonagh. Good morning, everyone. Thanks so much for joining us. As Oonagh mentioned, my name's Rebecca McAuley. I'm the best practice specialist here in HCI, and I'm going to be presenting our HIQA inspection report summary this morning. So just for a bit of context, on the 8th of June, HIQA published 50 inspection reports on residential centres for older people. They were inspections that took place between October of last year and March of this year. Of those 50 inspections, HIQA found evidence of general good practice and compliance with the regulations and standards. 29 of those 50 centres were found to be fully compliant or substantially compliant with those regulations. Of the centres that showed areas of non-compliance, we've analysed 15 of those HIQA reports to identify sort of key areas of non-compliance and the types of findings under the regulations of those non-conformances. So today we're going to focus primarily on the 6 regulations under which high risk or the red rated findings were recorded, and we'll also explore some of the other regulations that had moderate risk findings. So the 6 regulations that had the high risk findings were governance and management, staffing, infection control, premises, residents' rights, and healthcare. So getting started then with Regulation 23, which is governance and management, and just to note that any findings that were specific to the likes of staffing or infection control under governance and management, we're going to touch on them a little bit later in the presentation under those respective regulations. So looking at high risk findings then under governance and management, one theme we see kind of coming through is insufficient safeguarding oversights, as Oonagh touched on briefly already. Safeguarding is a big one. So examples of these findings included things like ineffective oversight and review of safeguarding instances. One finding showing that following a safeguarding investigation involving a staff member, there was issues with disciplinary processes not being followed and not being implemented. Issues with safeguarding assessments not being completed accurately or failing to consider all relevant factors. In a specific example there, one finding showing that 2 safeguarding assessments were inaccurately completed and a third where not all relevant factors had been considered in the resident safeguarding assessment. So you can see from those findings there were issues where safeguarding incidents are not being investigated, but oversight systems, where safeguarding incidents were being investigated, but oversight systems were not sufficient to ensure that those findings were actually acted upon, ultimately posing a risk that residents were not being adequately safeguarded. The second theme that sort of comes out when we look at the findings under governance and management relate to ineffective incident management. One finding showing that even though incident reporting processes were in place within a centre, they had failed to actually identify cases where assessments had not been completed correctly or where policies had not been adhered to in practice. And another finding following a serious incident review, learnings identified had not been implemented, and this had included an action plan for a staff member, which involved increased supervision and manual handling training. And it was found on inspection that that action plan had not been followed through with. So these findings again showing that although incident management processes were in place, they were actually failing to identify poor practice or actively drive learning. Third theme then that we see coming out under the governance and management findings relates to audit systems that were not driving improvement. So this is a combination of both high and moderate risk findings. These are demonstrated where things like audits were being completed, but findings not being acted upon, where there was clear disparities between the internal audit results within centres and HIQA inspection. So internally, centres completing audits and finding that they're compliant in different areas, and then when HIQA come in, their inspection findings contradict those audit findings. Findings where there was a lack of time-bound action plans in place based on audit results, or actions from previous compliance plans that had been established had not actually been implemented. Looking at some specific examples then of the sorts of findings that show audit systems were not driving improvement. You have a finding there where a falls audit was completed, but it failed to link falls with inadequate staffing levels and supervision, and recommended actions, from that audit were not evident on the days of inspection. Another finding showing there that staff were not being informed of low compliance scores or areas identified for improvement. So audit findings were not being effectively relayed to staff in those specific areas and therefore not driving improvement. Again, a wound care audit, which identified a need for a specific dressing regime, was not adhered to, and there was a lack of evidence to show that those recommendations or instructions were actioned when on the day of the inspection. Another finding showing that audits had indicated there was full compliance in maintaining the privacy of residents. However, the inspection of the residents' rooms had directly contradicted this audit finding. There was issues with multi-occupancy rooms and lack of adequate privacy screens. And the final example here, then, a finding where an annual quality and safety review was being completed. However, they did not include a development of a quality improvement plan for the following year, so no measurable improvement targets have actually been set. So we can see from these examples where audits were being completed but were not translating into meaningful change, where findings weren't being acted upon, action plans were lacking clear timeframes, and then again, when inspection results were directly contradicting what internal audits had been recording as compliant. Next, then, we're going to have a look at Regulation 9, which is residents' rights. So, some high risk findings under this regulation related really to a failure to ensure residents could undertake personal activities in private. And this was demonstrated where residents were unable to close the door of an ensuite while using the toilet or using the shower, and where CCTV was in operation in areas where residents would normally expect to have privacy within the centre, so the likes of day rooms, sitting rooms. And there was limited signage in place to inform residents of the fact that CCTV was in operation in that case. Looking at some of the moderate risk findings and under resident rights, again, privacy concerns come up, findings showing that there's inadequate privacy screening in twin rooms, issues with access to an only bath in the centre, not freely accessible, and residents have to request a key to gain access. And then findings relating to residents' contracts. There was a finding where there was unfair contract conditions imposed on residents, and the provider was reserving the right to increase accommodation charges up to 4 times in a year. Continuing on with moderate risk findings under residents' rights, then there was findings that indicated issues with choice, consent, and access. So staff being observed placing clothing protectors on residents during meal times without, effectively engaging with the resident or actually asking their permission to do so. Areas within a centre where residents had flagged as needing improvement were not being addressed by management. Access to a garden area. Residents were required to walk through a smoking facility to gain access to a garden area with no alternative access route available. And then another finding, residents observed by inspectors without access to their call bells. And then finally, relating to residents' rights, there's findings around the provision of advocacy and information to residents. So inspectors had found in some cases independent advocacy services within centres was not available to residents. In one case, an advertised in-person advocacy awareness campaign had not taken place, despite the fact that it had been displayed and advertised within the centre. And in another case, the provision of residents' guide and information on the centre's complaints policy had been recorded as not applicable on a resident's admission records, and that's despite the fact that providing, adequate information to residents on the residents' guide and complaints policy is a regulatory requirement. So taken together, these findings really highlight that for some residents, HIQA found that basic rights to privacy, choice, information, and advocacy were not being consistently upheld within some centres. Looking then at Regulation 27, infection prevention, so quite a few findings around IPC. The number of high-risk non-compliant findings then to explore. So the first theme, again, that we sort of emerge is looking at infection prevention findings relate to governance and oversight failures. So example of these findings were things like ineffective management systems, which were contributing directly to IPC failures. This is being driven by things like poor outbreak communication and oversight, and this resulted in risks not being identified or escalated in a timely manner. Then again, management systems not ensuring that ongoing outbreaks of infection were being sufficiently managed to protect residents from infection, and findings that showed reviews had been completed following prior outbreaks of infection were found they had failed to identify areas of concern that were then identified by HIQA during their inspection. So we can see here these findings show that at a high level, governance and management structures were kind of failing to identify, to escalate and respond to IPC risks in an effective and timely manner. Looking now at high risk findings that related specifically to the management of infectious outbreaks. So in one particular centre, there had been 3 significant outbreaks in the previous 5 months. They had found that there was a failure to carry out a deep clean of the centre following a previous outbreak of norovirus, and there was a failure to enhance cleaning services during that outbreak. And then during another previous outbreak, care staff had been assigned to complete enhanced cleaning duties on top of their responsibilities and care provisions, so that was also found to be impacting care capacity. Then looking at some high-risk findings relating to the management of an ongoing outbreak that was in progress during a HIQA inspection. HIQA found that housekeeping hours had not been sufficiently increased during the ongoing outbreak, so enhanced cleaning was not taking place. HIQA found poor communication with staff and visitors with regards to that ongoing outbreak. They found there was a lack of signage to highlight that the centre was in an active outbreak. Some night staff duty were unaware of the fact that the centre was experiencing an active outbreak. And inspectors also concluded that a poor uptake of vaccinations among staff and residents was likely a contributing factor to the issues with outbreaks. Um, so together, these findings really highlight sort of significant gaps across multiple aspects of outbreak management. So from environmental hygiene to issues with staffing resources and general communication, and general effective infection prevention measures. Looking then at some other high risk findings in relation to IPC. So you have issues with environment and equipment there. So kitchen and residence equipment being visibly unclean on inspection. Cleaning equipment such as damp cloths that were being used, being reused, cloths that were being used to clean high touch surfaces were being reused and left in bathrooms. High risk of germs multiplying and then being spread. Linens not being effectively segregated. Soiled and infected linen not going into the red soluble bags. And in one case, cleaning records for some toilets had not been updated in 5 months at the time of the inspection. So again, an issue around records there as well. Continuing on with some more high risk findings, lack of issues with hand hygiene, so lack of access to clinical wash basins, lack of a designated treatment room with hand hygiene facilities so that high dressings and medications could be prepared safely, and then issues around sharps management, needles, lacking safety devices, sharps box not being managed appropriately, not being signed or dated or closed correctly, and all of which were obviously contributing to the risk of needle stick injuries to staff. Then looking at some of the moderate risk findings under IPC, so several findings which relate to ineffective IPC monitoring. So these are things like internal audit processes not being robust enough to identify risks in the environment. In another finding, monthly internal IPC audits were indicating compliance. However, these findings were directly contradicted by HIQA on their inspection, where they had found visibly dirty areas within the centre. In another case, antimicrobial consumption monitoring was being conducted on a monthly basis. However, it was not being actively used to, identify trends. It wasn't being used to detect increases in incidence of infection within the centre. And that particular case, it was found that oversight resulted in an acute respiratory illness outbreak going undetected. So again, linking back there to ineffective audit processes, which we've already touched on a bit. So across these findings, we can really see that even where monitoring activity was taking place, it wasn't really identifying the risks present, and it wasn't really translating that data into any sort of meaningful action. Looking then now at Regulation 15, which is staffing. So the first theme under staffing are findings that relate to inadequate supervision, staffing levels and skill mix. So issues around insufficient staffing resources to ensure effective care delivery. Specifically examples there where in one particular centre there was a finding that there was 3 full-time HCA and 1 full-time nursing vacancy at the time of the inspection. In another finding, 1 nurse and 1 care assistant were found to be on duty for caring for 28 residents on a night shift. Another finding showing that a provider had continued to admit residents despite known insufficiencies in staff levels within the centre, and that was found to be placing an increased workload on existing stretched resources in that case. Continuing on with those findings relating to supervision, skill mix and staffing levels. So findings that showed systems to ensure that staff received appropriate supervision and adequate support to adhere to best practice were not effective. In another finding, there was poor oversight of unplanned leave, ineffective system for ensuring the centre was staffed on a daily basis. In that particular case, on the first day of the HIQA inspection, it was noted there was a 20 care hour gap in the roster due to unplanned leave. On the second day of inspection, there was a 12-hour gap in the roster. And then more findings that sort of show issues with poor staff communication systems. So that things like lack of schedule of staff meetings, staff not being adequately informed about audit findings in relation to the areas that they're working in, and issues with two-way communication between staff and management not being ensured. Looking then at how those non-compliant findings actually directly translate into impact on residents. So, you have findings there showing that there was inadequate provision of one-to-one activities or residents who required them due to issues with staffing, residents being left waiting prolonged periods for assistance with things like hygiene, assisting to bed, mobilising, administration of medications, issues with general supervision and general provision of care. One finding there showing that there was failure to provide increased levels of monitoring following a safeguarding incident, which was a direct result of insufficient staffing levels. So these findings really show that, insufficient staffing levels and issues with skill mix on top of inadequate oversight and communication systems can have a really significant impact on multiple aspects of care delivery within the centre. Moving on then to Regulation 6, which is healthcare. So there was just one high risk finding under this regulation of the 15 reports we reviewed, and that was a failure to provide appropriate healthcare in accordance with professional guidelines. So this was sort of demonstrate where care was not being delivered in line with the residents' care plan. Specifically, there was issues with the delivery of IPC practices that were not aligned with evidence-based guidelines to adequately protect residents from developing healthcare-associated infections. There was issues around nursing documentation and communication, which did not align with best practice guidelines, and a lack of clinical documentation oversight. So, for example, there was issues with fluid intake records for a resident who required intake output monitoring were not completed. Next, then we're moving on to Regulation 17, which is premises. So some high risk findings related to premises were really failure to ensure that the premises was conforming to Schedule 6, the regulations. And this is demonstrated by things like dryers not being commissioned that resulted in laundry being transferred through the centre, through resident areas, posing a risk of cross-infection to residents where there was issues with contaminated laundry. An oven in the kitchen found to be out of order for an extended period. Issues of decor within the centre showing significant signs of wear and tear. Floor coverings and wood finishes worn and not facilitating effective cleaning. Continuing on then with those high risk findings, again, shower tray design also not facilitating effective cleaning, encouraging the accumulation of dirt and biofilm. So linking back a bit with IPC there as well. Issues with the garden path being uneven, residents not being able to safely walk within the garden because of it. Inappropriate storage of cleaning chemicals in the manager's office. And then HIQA also found that the noise of a toilet flushing in one case along a corridor was generating a loud banging noise, which they found to be disruptive to residents, impacting their ability to rest during the day. Some of the moderate risk findings then in relation to premises, they include things like premises not conforming to the registered statement of purpose or to the registered floor plans. Again, issues with general wear and tear within the centre, chipped paintwork, ripped upholstery, carpet, couches, that sort of thing. Equipment like Zimmer frames and linen skips and wheelchairs being inappropriately stored in assisted bathrooms, and as well as residents not having adequate storage for their personal belongings. So across the findings, you see the physical environment in some centres was sort of deteriorated to a point where they were not only failing to meet the regulatory requirements, but the inspectors found they were actively posing a risk to safety and hygiene and comfort as well. So that brings us to the end of the 6 key regulations that had high risk findings outlined in the beginning. We're just going to have a look now at some of the other regulations that had moderate non-conformant findings. So the first one there is Regulation 16, which is training and staff development. So some moderate risk findings relating to training gaps. These included things like mandatory safeguarding and CPR training not being up to date. A case where staff who required refresher training in safeguarding following a safeguarding incident did not complete it. Staff not demonstrating appropriate knowledge in the management of infectious outbreaks or knowledge with medication management. Catering staff not received appropriate training for the safe preparation and handling of foods, which included modified and therapeutic diets. Staff unable to demonstrate appropriate knowledge of modified consistency diets to ensure that residents were actually receiving meals in line with their prescribed dietary requirements. There are also some moderate risk findings that related to monitoring and oversight of residents, which included findings where staff were not familiar with residents who required enhanced supervision or not being aware of residents who were at high risk of falls, and issues of call bells going unanswered for long periods, inspectors observing that call bells going unanswered while staff were in the vicinity and engaging in non-essential tasks. And finally, some moderate risk findings related to staff conduct, performance and management. So one finding showing that a staff member who required enhanced supervision following a safeguarding incident did not have a performance review completed, and there was no reference to ongoing supervision requirements in their record, despite the fact that they had been flagged for extended mentoring. In another finding, inspectors observed a staff member had not received a handover of the residents in their care, again linking back to safe delivery of care and effective communication. And then staff also had observed unsafe and undignified practices directly observed by the inspectors, staff not communicating with residents when assisting with meals, meals being served on tables unsuitable or inaccessible to residents. So these findings really show the visible impacts of unsafe quality care delivery when staff performance isn't being adequately managed or monitored. Looking then at Regulation 5, individual assessment and care planning. Some moderate risk findings under this regulation really focused on gaps in nursing assessments and care planning, particularly around pressure injury as well. Here, there's a few findings. So, in one finding, residents who had pressure ulcers or pressure injuries were incorrectly assessed as being low risk for developing pressure injuries when in fact they were living with one. It was found that repositioning schedules and the use of pressure relieving equipment was not being appropriately incorporated into care plans where they were required. And in one case, a resident with a high grade pressure ulcer had no pressure relieving mattress in place. There are also several findings that show care plans were not being consistently updated to reflect residents' current needs. So many active care plans containing outdated or irrelevant information, risking issues with communication of inaccurate care needs to staff. This included care plans on responsive behaviour, care plans on the use of restraint, safeguarding care plans. So again, overall presenting a risk of inappropriate intervention or a failure to actually protect a vulnerable resident where inaccurate information was being recorded there. Another issue that emerged under Regulation 5 were issues with using generic or pre-populated care plans. So this included findings that showed standardised safeguarding plans were actually being used in some cases. These standardised plans not based on the assessed needs of the resident didn't provide specific measures to support resident needs, and in cases staff were unaware of specific safeguarding concerns that were in place as a result of that. And then another finding, generic response behavioural care plan was found to be in place for a resident who actually had no assessed need for such a care plan. So you can see from these findings where assessments were inaccurate and care plans were not kept up to date, the direct consequence was that residents were not receiving care in line with their actual assessed needs. The next one then is Regulation 25, temporary absence or discharge of residents. So a few moderate risk rated findings here. One where a resident was denied readmission without prior discussion after being transferred to an acute setting. Readmission was refused by the centre on the basis that the provider could no longer meet the resident's care needs, and HIQA inspectors determined that the resident's rights were not upheld and their discharge was neither planned nor safe. In another finding, incomplete transfer documentation was being sent with residents, again being transferred to acute hospital settings, and that was despite the fact that the national transfer letter was available on the system but was incomplete for the sample of residents that were inspected. Another finding there showing a lack of evidence to show that all relevant information about a resident had been provided to a receiving hospital to which the resident was transferred. And we can see how these gaps could really impact on the safety and continuity of care for residents during transfer or discharge to different settings. Regulation 26, then risk management. One finding here, risks from reduced housekeeping hours and high staff turnover was not identified or assessed on the risk register. Then Regulation 18, which is food and nutrition. Residents' dietary needs were not being consistently met. Findings that showed prescribed modified texture diets were not always available to residents. There was a lack of choice or consultation with residents regarding their meal preferences. And again, tying back a little bit to residents' rights there as well. Then we have Regulation 14, which is written policies and procedures, some moderate risk findings around things like policies not containing the specified requirements as detailed in the regulations, where policies are not being effectively updated to reflect current regulations, guidelines, current best practices, and policies not being dated, couldn't determine when the policies were written, complaints policies not being accessible to those residents who didn't have English as a first language, and issues around medication management policies and procedures not being actually implemented in practice. So these findings really underline the importance of not just having policies in place, but also maintaining them with regular review, having clear version control for policies, dated records, and having audit schedules that actively monitor whether policies are being adhered to in practice. So that brings us to the end of our inspection findings review. So just a quick summary of some of the high risk findings we've covered. A review of those 15 inspection reports, we've identified as having high risk red rated findings for a few of the key regulations. So the first one, their governance and management systems, so that we're not ensuring services were safe, consistent, or effectively monitored, and issues with audit systems failing to translate findings into meaningful improvement. Residents' rights, then failures where where it was found that upholding residents' rights was not being consistent, was not consistent across centres, and particularly focused on residents being unable to undertake personal activities in private. IPC procedures that were not consistently in place or implemented, and outbreaks not being managed in line with national guidelines. Staffing levels and skill mix were not consistently meeting the assessed needs of residents, and there was a direct and demonstrable impact on the care they received as a result of that. Under healthcare, then, care not being delivered in line with residents' individual care plans, and premises, the physical environment not being maintained to the standard required to support safe and effective care delivery. So that brings us to the end of our review of the HIQA inspection reports. And I'd just like to move on briefly to some key documents for providers to be aware of. There's a few that have been released since our last webinar that we just want to draw your attention to. So the first one here, the HSE Incident Management Framework and Open Disclosure Audit Tool. This was released in January 2026. So it's a helpful tool that supports services in implementing the HSE Incident Management Framework and assesses compliance with the management of Category 1 and Category 2 instances. It's designed as a self-assessment tool, and it can be used for peer-to-peer audits or by external agencies to provide assurance that incident management principles are embedded in practice. And given some of the findings that we saw under governance and management around ineffective incident management and governance oversight, the tool is a very useful resource for providers. Also of relevance here, given the number of findings we saw under Regulation 27 infection control, we'd like to draw your attention to the HSE AMRIC, which is the Antimicrobial Resistance and Infection Control Competency Framework for Infection Prevention and Control Practitioners in Ireland. This was released in May 2026. It's a framework that outlines the core knowledge, skills and abilities required for healthcare professionals pursuing a specialist career in IPC, and the target audience will be health and care professionals that are currently engaged in specialist career in IPC or considering specialist career in IPC, as well as those who work in IPC and antimicrobial stewardship, education, training, evaluation, management, and clinical service delivery. And finally, this is one that Oonagh touched on at the beginning of the presentation, but we want to draw attention to the National Safeguarding Office, which has published a number of updated adult safeguarding practice guidelines, and they're listed here, with the guidance documents taking effect from 1st of July 2026. So we're very prompt here with these. These documents support services, including residential centres, to really align their safeguarding practices with current safeguarding policy. These guides provide practical directions on prevention, responding to concerns, screening, safeguarding planning, risk communication, peer abuse, and a variety of other bits and pieces. So given some of the findings around safeguarding that we covered earlier in the presentation, we can see that these guidelines are particularly relevant and give providers a really good framework to help strengthen their safeguarding processes and governance. So on that note, I'm going to hand over to Oonagh briefly just for some closing words on our summary of the HIQA inspection report findings. So thank you all very much. I'll hand back to Oonagh.
Thank you very much. Thanks, Rebecca, and some very very poignant information there, and certainly something that is worth considering and seeing how services benchmark against some of those non-conformance findings. I think what is certainly prudent is that although the regulatory framework landscape may be reasonably stable, the changes are continual in relation to the guidance documents and supports, and we've certainly seen that very much in relation to the IPC findings that are there, where best practice isn't being incorporated in processes and not being rolled out to staff on the ground. And we also see it as, again, in relation to the safeguarding, there's a continual movement and improvement in various sectors that providers need to keep up to date with and ensure that their processes and their policies and procedures are reflective of those. So with that in mind, how can we help? Well, HCI have a full suite of policies and procedures for older person services that reflect the ongoing best practice and requirements that are there, and that is a continually monitored process. On an ongoing basis, we are monitoring the suites of websites to ensure that it incorporates all guidance and best practice within each of the systems. To access that kind of content, we do that via our Clodagh digital solution. And this is where I'm going to bring in Tanya, and she's going to give us a quick demo on how the Clodagh model works and how it can address some of the key content issues that we presented or Rebecca presented on this morning. So, Tanya, I'll hand over to you.
And yeah, thank you very much, everyone. I'm Tanya. I'm Business Development Executive here at HCI, and I'm just going to do a brief demo and walk us through Clodagh. So Clodagh is our digital quality management system, and I'm going to just take us through a bit of the functionality here. We have our AI digital assistant, Clodagh. We have our library for storing and managing your documents, and where you have the permissions to do so, also create those documentation. We have our training room where you check mandatory training against your staff, and where you have the permissions to do so, you will have access as well to the analysis, the admin, and the configuration. And just as Oonagh just mentioned there as well, our best practice templates, these are provided with Clodagh. It's part of our service here at HCI. So you will have the best practice templates aligned with older person services, aligned with HIQA regs and standards. And as part of the agreement, should that happen, that will be included with Clodagh. So just jumping in now to Clodagh here. I'm in a nursing home environment, and this is in desktop version, but you can also access Clodagh via mobile. So I'm going to ask Clodagh a question here. It's our AI digital assistant, accessible 24/7, where you can ask questions. Clodagh gives you answers. All of the questions that you ask Clodagh can only answer giving the information that you provide. So your documentation that has been approved, that has been up to date, that is active, that is Clodagh's brain. She does not access any external sources to provide information. So just be reassured by that. So I've asked a question here related to infectious outbreak. Clodagh has identified that this links to two documentations within your organization, for example, in this nursing home environment. So I click here into the policy, and we can see here, we have here as well, just to also highlight, there's your policy and your information to access. Anything written in blue here, this is new guidance that has emerged, and all revisions are going to be written in blue, so that's easily identifiable and it's always kept up to date. So again, that's part of the service here. When you do have access to those best practice templates, you'll also have access to any ongoing revisions. Now, here we have this document. I need to actually acknowledge it. So when this document was created, we actually attached a quiz to it. Now, quizzes are not mandatory. It's completely customizable, but what we have found is that with quizzes, staff spend 3 minutes acknowledging the policy rather than 3 seconds. So it's a great way for you to also demonstrate to HIQA and to your management team that your staff is spending time on the documents and being able to understand them. So here I've only got 1 out of 6 correct. So I need to reread the document, retake the quiz, and Clodagh will not provide me with the correct answers. I need to keep doing the quiz until I get them correct. So again, understanding that and being able to demonstrate that compliance and that comprehension. So just to quickly also highlight here, I've got this uploaded, but Clodagh is also multilingual. So for your staff that do have English as a second language, I've asked a question in Spanish. Clodagh has responded in Spanish. Your documentation, though, will still be in English for that standardization. Okay? So just want to highlight that there. Now, moving back into the demo, your library here, again, this is where you store your documents. These are customizable tiles. Right now, we have them reflective of the HIQA themes, but you can customize them, and your document management here is where you have the permissions to do so. You can create a document, and it will give you the status of it. Okay, so you can have it nicely, neatly organized like that. Then into the training room, as I said, this is where you can manage your mandatory training against your staff and check the compliance there. You upload your certificates and completed documentation and be able to mark that as complete. As mentioned, where you have the permissions to do so, you will be able to get these analytics, okay? So here we have doc review, where management can see what documents are outstanding, what needs to be checked for review, what is overdue, next 30 days, 90, and you can filter this right down to the owner, the author, etc. Similarly, for training, you can see what training is outstanding, and again, break that right down to the job role, the department, the location, and the status of it being overdue, etc. Now looking here similarly for your policies and procedures or any documentation that is outstanding, you can see right here what is needing to be acknowledged. I'm going to filter this right down to outstanding and look directly at the nursing department, have a look along here. I can see everything that's outstanding. I can tick along here and send everyone who has not completed their acknowledgements here a reminder. So that is just a brief whistle-stop tour. Just want to also mention here, just briefly back at Clodagh, she is here at 24 hours accessible. What we are finding is that staff, there's 29% of staff are accessing Clodagh outside of standard business hours. So those are great insights that you'll be able to see should you be part of the management team. And also we have been able to return 500 hours back into care through the instant access that Clodagh gives. So that's time that was saved on doing admin or having to search for policies. Per 100 staff organization, 500 hours returned back to care just by being able to do things like being able to access your policies straight away, going back into Clodagh, being able to see where your training's due, etc. So I just want to say thank you very much. Very quick whistle stop tour there. We are happy to take you on for a more in-depth demo. Just book that in, and we have our audit module coming so soon. So we'll be happy to give you a sneak peek of that as well.
Thank you so much, Tanya. That is a whistle-stop tour, but a very effective one. Certainly the wonders of modern technology, but certainly that short question asking is such a useful tool where you can just type in some key questions and it will provide the information to you directly from your policies and procedures and link you through. I mean, it has been hugely effective. 500 hours, that is really impressive numbers, certainly that we can give back into care, and that can only be a good thing. That's it, folks, for this morning. Thank you so much for taking the time to join us. Hopefully we'll see you back here again soon for another webinar, and we'll make sure that we keep an eye on all key content, keep you up to date as much as we possibly can. So thank you very much to everybody, and hope you have a good day.